with the Dutch protocol on the simple basis of one cohort study of 70 patients. Gilles, I give you the microphone.
Yes, thank you. So this is, of course, a very important question, but also a very complex question. And I can only present 8 possible explanations, and just as a starting point for more research. And in fact, the Dutch protocol, especially puberty blockers, was already spreading before the 2 Amsterdam studies on this small cohort came out in 2011 and in 2014. So how can we explain this? I'll draw from the more general literature on explanations for the adoption of medical innovations without sufficient evidence, because unfortunately this is quite a common phenomenon. And that literature applies very well to the development and subsequent spread of the Dutch protocol. So my first explanation, which is simply that doctors find it extremely hard to do nothing. So this first explanation has to do with the dynamics between the gender clinicians and their patients. So doctors by nature want to help their patients. And they find it very hard to do nothing when they see their patients suffering. And this is really important. Gender dysphoria may sometimes involve intense suffering. And from the literature and from talking to a whole number of gender clinicians, it has become very clear to me that gender dysphoric patients may sometimes strong appeals to gender clinicians. And this appeal to give them puberty blockers is felt really strongly by these clinicians. Even when I talk to them, I can feel how difficult it is for them to say no. And it was also because puberty blockers at that time were presented as fully reversible, relatively harmless, just buying time. So it was in fact presented as a highly attractive option with no real costs, and therefore much more attractive than doing nothing. So it's really important that we try to understand the mind and the situation and the context of these gender clinicians to understand why it started and why it still continues today. The second is the so-called therapeutic illusion. Gender clinicians often tell that puberty blockers give immediate relief to gender dysphoric children. So when you're talking to them, this is something they emphasize very strongly. So when you ask them about the lack of sufficient evidence, they often appeal to their clinical observation. We just know that it works, they say. So it seems to me that gender clinicians are particularly vulnerable to the therapeutic illusion. The belief that their treatment is effective when it is in fact not. And I believe that this also, and this is important, makes them very good advocates for their treatments. For example, the Dutch clinic has been very helpful to start up several gender clinics in other countries. So they have been actively exporting their product, so to say. And in the literature, you can find even various references by clinicians from other countries to the apparent success of the Dutch protocol at times when there was no evidence at all. My third explanation, and this is the hypothesis of gender dysphoria having a biological origin. Around the 2000s, the Dutch clearly suggested that gender dysphoria has most likely a biological origin. And because of that, it should be presumed to be permanent, and therefore starting medical treatment already in minors would be justifiable. Now, the basic idea was that gender dysphoria involved some idea of having a brain sex different from your body, incongruent to your body. And that was popularized as the idea born into the wrong body. And, well, that sort of language is clearly inaccurate, but it provided very easy. It proved to be very easy to relate to in media stories depicting children who also see themselves in that way or are presented in that way. So it is also very easy to feel compassion with children which are supposedly being born in the wrong body. And that's exactly what happened. If you just read these old media coverage of these cases from the Netherlands from 2002, 2010, it's always the same story. Poor children born in the wrong body who suffer intent and with whom it is very easy to have compassion. And if then you can give them puberty blockers to spare them that suffering and to hopefully give them a better life as an adult, better passing, then it's quite natural to sympathize with such stories as a general public. Now, that also relates to my fourth factor, which is the frame of emancipation and human rights. This has been there from the very beginning. And this made gender dysphoria as something exceptional. And that also made it the case that it wasn't treated in the framework of regular medicine. So different norms were in fact applied. And that was also, I think, a reason that less good evidence was accepted. Now, my fifth potential explanation is the solid reputation of the Amsterdam Free University Medical Center. This, from the beginning, had successfully created a public image of being very careful, doing much research on their new treatment and changes in their treatment protocols. And it's also interesting that the Amsterdam Hospital originally is a Protestant Christian university. And as I said, compassion was one of their self-ascribed motivations for providing pediatric gender care. And it would be very interesting to investigate this explanation further. 6, very interesting from my perspective as a medical ethicist, I think we can discern a systematic pattern of denial and reversal of the burden of proof. So over the years, gender clinicians have been remarkably successful in not only evading their burden of proof, but also in even placing this burden on their critics who are opposing the Dutch protocol. I'll read a quote from a 2008 paper. Realizing the potential harmfulness of non-intervention, one may even wonder whether not providing treatment may not only be doubtful on ethical grounds, but also have legal implications. So, instead of providing positive evidence for an overall benefit of their treatment that they innovated, they appeal to the presumed and potential harms of non-treatment. So this is a complete reversal of the burden of proof. And it's astonishing that this has been accepted, but it has. And this is still going on, because that's still one of the most important, and I'm finishing, most important arguments. 7, in pediatric gender care, off-label use of medicine is very common. So in this sense, it's just an instance of a general pattern. But of course, it's a very different and very problematic instance. And the 8th, final, is the role of parents and interest groups. Because also in the Netherlands, in some ways, the parents and their interest groups have been pushing even harder than the gender clinics themselves. Thank you.